The Genuine Article. Discussion and commentary based on articles from JACC.
Hello, I'm Tony DeMaria, the editor of JACC, here with another issue of The Genuine Article. And I'm talking to Bob Schwartz, who's probably well known to all of you. Bob is the medical director of the Minneapolis Heart Foundation, and he's the primary author of a really important paper in JACC that deals with microemboli in the setting of acute myocardial infarction. How did you get interested in this problem, Bob?
Tony, this is an interesting issue. We know from MRI imaging that microvascular obstruction is very prevalent. First question is, what in fact is there? So I turned to our good friend Renu Vermani, and said, Renu, let's look at some of these hearts, sudden death from cardiac cause, and see what's actually there in the microvasculature.
So you are actually examining necropsy specimens from sudden death.
Coroner's cases, sudden death, 44 hearts, exactly.
And how much microvascular obstruction did you find?
Every heart had some microvascular obstruction. This all is well known. For example, all TIMI-3 flow. After a stent has been placed, there's about 40% of those hearts that still have microvascular obstruction.
Sure. Now, in the old days of contrast echo, we used to call that the no reflow phenomena. That the thing you're dealing with?
Probably. It's never been shown that the two are together, but on the other hand, now several studies have come out. We, in fact, published in the past on this. This is dense platelet emboli principally that are in the microvasculature, completely obstructing these tiny blood vessels, less than about 200 microns in size.
And so what exactly predisposes to the formation of these platelets?
Well, it was interesting, the collaboration with a pathologist, obviously as well known as Dr. Vermani, their stand was, what is the epicardial plaque characterization that in fact caused this? So two characterizations, plaque rupture and plaque erosion. So that was the content of the paper, was what is the relative embolization microvascular obstruction rate between those two morphologic epicardial coronary plaque types.
And what did you find?
We found, interestingly, the erosion defined as thrombus on the epicardial, within the lumen of that coronary artery, not consistent or not touching the necrotic core, is far and away more likely to embolize, far and away more common in women, interestingly, and also much more likely to cause myocardial necrosis.
So we usually think of plaques rupturing as the major cause of infarction. Substantially less number of plaque erosions, but in your study, the plaque erosions played a really important role in the microvascular obstruction.
Exactly. Seemed to be a substantially worse cause. On the other hand, we need to realize this was a very small sample size and very highly selected.
And I guess there's no easy way to identify whether a plaque has ruptured or whether it's eroded.
Well, perhaps in the days of OCT, we'll be able to see that in living patients. The interesting thing there will be to do the pathologic correlates. But in pathology, it is actually quite straightforward to define the differentiation between an eroded plaque versus a ruptured plaque. These are well defined in the path literature.
Now, given your observations, are there any therapeutic implications?
Terrific question. We don't know, but I think the first step toward understanding whether we can treat this microvascular obstruction is to understand what is there. And it is principally, as I said, 200 micron or less vessels that are almost completely platelet emboli, completely solid, dense platelet thrombus. So we need to attack those platelets, recognizing that standard lytics don't touch platelets at all.
You know, well, the events after myocardial infarction in the microvasculature have been an important focus for a while, and there's a litany of interventions that have failed, but your observations may be critically important in guiding us to something that's more successful.
Well, especially if we can treat it locally. In the cath lab, isolate that circulation and perhaps then go after this problem in a local context. Higher concentrations of drugs, new drugs, perhaps cocktails. There are many potential new options to consider.
Well, you've certainly set the stage for coming up with something that'll help us overcome this problem of microvascular obstruction. Thanks very much for being with us.